Rosie. I'm sat with Rosie Russell here, and this is a pre-recorded webinar, which is not something that we usually do, but I have made a request for questions, and I've got at least one very meaty one back. Plus, it's very rare that I listen to these things and don't have my own questions. So I'm hoping that by the end of this, we'll have a really good insight into the topic that Rosie's offering today. So Rosie is the president of IIRSM. She's also the Director of Environment, Health, Safety and Sustainability for Mira GTX. So thank you so much for agreeing to do this for us, Rosie, today.
Not a problem. I'm very glad to be here.
So this is being run on behalf of Women in Health and Safety, but where I will be sending it out to my whole database, be posting it on LinkedIn, so it won't just be for the women in health and safety, for anyone that's in health and safety. And you've called this presentation Baseline Safety. And as I understand it, what we're going to be discussing is how equality, diversity, and inclusion, how being from a minority can affect your experience of health and safety. Is that right?
That's absolutely right. In fact, really, I'm having a dig directly at one of the basis or the fundamental basis of our profession, which is risk assessment. And saying,
Okay.
are our risk assessments actually taking into account everything? And I'm going to argue rather controversially, they're not.
Very good. Very good. Well, I mean, risk assessment is always a topic that everybody wants to discuss. There are either not enough of them or they're not suitable and sufficient. And I suspect that there is a mix of both of those things going on from what I can see. But I'm going to shut up now and hand over to you, Rosie, to do the presentation. I'm going to take some copious notes and think about what I can ask you at the end.
Thank you very much, Heather. So the talk, as you say, is entitled Baseline Safety. The concept really there is how much safety or how safe can we feel when we leave our front door? It's not the same for us all. We make very different assumptions. And where I really want to start getting us thinking on this is a concept of a night out on the town, something that I hope most of us enjoy. You may have seen some research on LinkedIn recently showing how, for instance, men and women perceive the environment that they're walking through. This was done using eye tracking, and what we find is that men are generally looking for obstacles in their way. They're looking in front of them. Women, however, are looking for threats and are looking around the periphery of the scene that is in front of us. So you can see immediately that our perception of safety is somewhat different. But if I pose a little thought experiment of 3 different groups going out on a night in the town, and it can be any city or town in the world, but it's 3 different groups going out in an environment that you're familiar with. And the first group, 3 men, they're mid-30s, they're reasonably fit, average build. They're dressed smart casual, nothing showy. They're native speakers of the local language and citizens of the country. Our second group, they're the same age, but they're women. We can see immediately that their assumption of how safe they are in exactly the same environment is different. Now, if I introduce the third group that were perhaps distinctly gender non-conforming, you can see very quickly that this group, perhaps of LGBT people, would assume again a yet lower level of safety. in that environment. It's the same city, the same venues, but the level of safety they can expect differs due to their personal characteristics. So that's quite easy for us to grasp. But how does that then relate to the world of work? Now, a while back, the European Agency for Safety and Health at Work published a document, Workplace Diversity and Risk Assessment. And it's titled Ensuring Everyone is Covered. And it makes the case for inclusive risk assessments. And that got me thinking, am I not being inclusive in my risk assessment? Well, given what's going on in certain parts of the world, we could say, oh, perhaps this is a complete overreach of equality, diversity, and inclusion, or equity, diversity, and inclusion, as I should be saying. Perhaps this is some new woke initiative of the European Union. Well, to start with, I'd like to say I am woke, because all that means is I'm aware and I'm willing to take on new knowledge. But it turns out that they were referencing one of the European Council directives. And it's actually Directive 89391 EEC. 89 being the year 1989, the year that the Berlin Wall came down. So that got me thinking because, well, I was still a teenager back then. Just. So I delved into the directive. And there it is in Article 6.2d, adapt the work to the individual. 9.1, groups of workers exposed to particular risks. Article 15, particularly sensitive risk groups must be protected against the dangers which specifically affect them. So this is hardly new. It's just our knowledge of those things has moved on since that directive was enacted. And we should really be responding to new knowledge with new initiatives. So what should we be looking at in terms of workplace diversity, and where are the gains that we can make? And more to the point, what evidence is there for this? And I went down a little bit of a rabbit hole and hit the library because that's what I do. So if we start in the area of personal protective equipment, we've seen there's been a lot of talk around inclusive PPE, and more to the point, PPE that fits specifically women. But I've got respiratory protection in the center there because almost 20 years ago, the standards around respiratory protection were revised to take account of different sizes of people, people from different ethnic backgrounds and different sexes. So it's actually as recently as about 20 years ago that the industry realized that one size really does not fit all. And if we're talking about respiratory protection, this actually is really vital. And I can remember about 20 years ago, my assistant, he was also doing our respiratory face fit testing. And he must have had 30 odd different types of disposable masks, more than a dozen half face and full face masks each, just to try and get a fit on everybody. And this was because these were all manufactured to the old standards. But even then, they were meant to be following a standard, but they were all clearly different and working in a very multicultural workplace. He had a real challenge finding respiratory protection that could fit everyone. And certainly he would have discussions with procurement about, can we not just buy from one supplier, please? And he had to explain. Now, it got better after the standards changed, and you got small, medium, and large in all of the different types. But even still, we were down to 7 or 8 different suppliers. So it was accepted because there was an actual test, a standard that you had to meet for respiratory protection, that we had to be truly inclusive with our PPE provision because we had to tailor that to the individual. Otherwise, we were not going to be able to protect people from the airborne contaminants. And in our case, at the time, I was working with airborne pathogens, so infectious agents. So this was really important. But we've now seen a campaign led by, for instance, people like Catherine Evans, who runs the Boulders Brass Tribe, and Deborah Janssen, and a few other people that have really been trying to get the standards around PPE revised and get people much more aware that PPE doesn't fit everyone. A male overall is absolutely no use for an 8-month pregnant woman. But that's one example. What do we do for the 6'8" bricklayer versus the 5'4" plumber, for instance? These are two people that I have actually dealt with in my career. So we now have the draft British Standard BS 30417, which will be coming out in its final version later on in the year. That's really now starting to get the industry to take into account all body shapes. But then that raises the question. You don't necessarily, if you want something that's going to fit you well, just order something off the peg and hope it fits. If it's an important occasion, you'll probably spend some time on the high street. You might have a fitting. You might have something altered for you. So if your workers' safety relies on PPE, does your onboarding include a fitting session? Do you have a range of sizes from a range of manufacturers with different thermal weights that'll take account for different people's tolerance of temperature? Or perhaps you've got some people going through menopause who might have hot flushes to deal with. Or are you selecting your PPE on convenience, on price, on ease of getting it from a particular manufacturer? Do you have different types of footwear that's made on different lasts, designed for men, women, people from the Far East? If you're not doing this, your PPE is not inclusive. And you can land up with ill-fitting PPE that can land up chafing or tripping people up, or 100 other ways that the PPE might actually interact with the work in a negative way and give rise to a risk that you're not controlling. So I would argue strongly that fitting sessions for PPE should become a thing. So now we move over into other areas of equity, diversity, inclusion. So if we take this group of people who are undertaking precarious work, or subcontractors moving from site to site, also migrant workers who are following, say, big construction projects and moving every year or so, or perhaps even people in the gig economy. This could be the literal gig economy, so setting up concerts and things like that, or it could be your Deliveroo rider. Well, it would be not unreasonable to think that people like this might have more accidents. And certainly that's the perception that I had going into this research. I was wrong. If you control for experience and for tenure, then these people have no more accidents than their equivalent people who are So living in the area or who have the same tenure or the same experience. So it's okay, isn't it, to have our subcontractors, things like that. Well, it turns out it's not the whole story. They don't have more accidents, they have worse accidents. 70% higher rate of accident involvement in serious injuries and fatalities. So they're not having more accidents, but they are undoubtedly at much, much higher risk. Yet that's despite the fact that this group of people have a 6% lower rate of all-cause mortality than local workers. They're actually healthier. They look after themselves better. Yet they put themselves in harm's way, perhaps more willingly, or is it a lack of understanding? And I'm asking that question quite simply because the data's not yet there to tell us why this is, just that it is. And the first clue, I think, as to maybe where the why might be is one of communication. How many times have you sat through a toolbox talk, for instance, and at the end of it, someone said, so we're all on the same page? What does everyone do? Nod. Oh, yeah, absolutely. The fact that half the audience is zoned out and the other half probably didn't understand half of it. Or you've done a briefing on a critical task. Right, everyone know what they're doing? There's no confirmation of understanding there whatsoever. And OSHA in the United States report that language barriers and communication issues are a root cause in 25% of all reportable accidents. We don't pay nearly enough attention to communication. We're not necessarily making our information, procedures, and training available to our workforce in a way that they can understand. Now, I first came across this actually again about 20 years ago, in the same job where I was dealing with the respiratory protection issues. We had a lot of Eastern European people working on a farm that was attached to our research institute. And we spent a lot of time where things were safety critical, putting pictures in our SOPs. And guess what? The communication worked. People could actually then confirm back understanding. Now, these days, we are in the days of Google Translate and other AI translation services. They might do a fair job, but there might be a point at which translators actually required. And certainly, we need to be confirming back that people have understood what we've said where it's safety critical. That might mean doing your safety briefing at the site of the task and having those workers talk you back through what's been agreed. Certainly, we've seen that for now over 50 years in the aviation industry. When pilots hand over control between one another, when they agree what a maneuver is going to be, they talk it back to the other pilot. There is no assumption of understanding made. And to be honest, I'm very glad of that because that's resulted in a 10-fold decrease in aviation accidents over the last 50 years. Yet we're not always doing this on our work sites. Now, let's move on. It's very easy to think that socioeconomic status is actually linked to hazard exposure. After all, the lower paid jobs are less safe, aren't they? Turns out we can control the risk exposure. There's a 2022 cohort study in Norway, taking a look at occupational road risk. They were able to control for miles traveled, vehicles traveled in, times of day. And what they found was, in terms of road risk, low socioeconomic status was associated with a higher severity of road accidents. That's fascinating to me. They've controlled for a lot of the other contributions, and they found that a low socioeconomic status means that you're more likely to be involved in an accident. They found a couple of other curious things, like actually being married is tied to a lower accident rate. I'm just going to let that one hang, and we can probably make our own comments there. But in this study on road risk, low socioeconomic status was associated with a 57% higher rate of hospitalization. Injuries with high threat to life were 125% more common for low versus high socioeconomic status, and such injuries were 100% more likely to be disabling. This seems to tell me that if we're talking about risk exposure with lower socioeconomic groups, it's incumbent on us to spend more time ensuring understanding and making sure that we truly understand their risk exposure. I can move on now to stress. And I know, Heather, this is your preferred or your mastermind topic, shall we say. But we know that stressed people have more accidents. We also know that stressed people have worse health outcomes. We intuitively know this. After all, how can you make the right decision if you're not in the right frame of mind? Thank you, Heather, for that quote. But there was a really interesting study done across a number of Italian hospitals. And what they were looking at was individuals with low decision latitude, so not able to make decisions about how and when their work was done. High workload. So this is the classic job strain that Karasek talked about in his 1979 paper. They then took a look at high and low manager support and then stratified the group for socioeconomic status. And something interesting happened. Yes, manager support, low or high, predicted accident involvement. Okay? So yes, even people in high socioeconomic status suffering classic job strain with low manager support were more likely to be involved in accidents. But there was a stratification up and down the socioeconomic status. In that, if we take a look at the top of the list, so consultant surgeons were in that group, they were 360% times more likely to be involved in an accident if they had low manager support than high manager support. If we head down to the bottom of that list to our, I guess, domestics and porters, they were 630% more likely to be involved in an accident. The socioeconomic status, independent of other measures, was predicted or predictive of almost a twofold increase in accident involvement. So not only is stress a predictor of accident involvement, so is socioeconomic status. And then we get on to neurodiversity. And this is a double-edged sword. We know that there are huge benefits from having different thinking styles in the workplace. People who join the dots and see things that other people just don't. And many neurotypes come with increased spatial awareness, lateral thinking, pattern recognition, ability to synthesize data. But dyslexics may need information in other forms. So we might need to have pictures in our SOPs, or we may have to have screen reading software available so that they can have SOPs read to them. People with ADHD and autism respond better to not just having verbal instructions, but having that backed up with written instructions. People who have dyscalculia might have problems with numbers on the fly. People with dyspraxia, problems with coordination and movement. But also certain neurotypes can get sensory overload in a crisis or an emergency. So you think, oh, okay, so maybe we select those people out of a high hazard environment. You'd be doing yourself a real disservice there, though, because they're actually more likely to spot the crisis before it happens. But you might have to consider how some people might react in a crisis. We talk about fight or flight, for instance. We forget freeze, which is actually quite often a response from certain neurotypes. So this was a fairly short run through some of the evidence that's emerging around equity, diversity, and inclusion characteristics, and that they are actually starting to show evidence that they are changing risk outcomes in the workplace. And I stop on my last slide here with this quote from John le Carre. A desk is a dangerous place from which to view the world. The problem is, as health and safety professionals, that tends to be where we view the world from. I can certainly say I know many, many people who would like to get out into the workplace more and actually see what's happening. Yet we land up tied up with endless paperwork. But I would argue that the emerging data around ED&I is telling us that we need to spend more time alongside our people and understanding how they see and understand risk, how they make decisions, and how risk outcomes might affect them differently.
Thank you, Rosie. Absolutely fascinating. And some of that I was familiar with, but some of it is a real eye opener. And I love that last phrase, and it really speaks to the blog post that I did at the weekend about the HSE Global series, and the fact that, you know, this idea that the health and safety professionals are drowning in paperwork and dashboards, and how much of that really makes a difference. And it's not just health and safety professionals. When you move further up the chain, you find that there's this big divide, isn't there? There's the people that actually sit at a desk all day, and then there's the people who are out on site. And if you get a supervisor who is taken away from that ability to be on site by doing something paperwork wise or what have you, you know, that's another thing which will impact people's safety.
I think it really is worth remembering for all policies, procedures, governance, data is important. If we lose that direct connection with our people, and more to the point, don't have the empathy to try and understand them, we will really miss how risk is experienced. And I often find one of the most powerful questions is, what don't you like about this job? Or what's difficult? Or if I could wave a magic wand, what would you change? What would make your life easier? giving people the permission to complain for a moment or two gives you a really rich vein of data.
And for me, that also speaks to another one of my hobby horses, which is the fact that, if you ask a question like that, which is the kind of question that I would ask when I go in and do a psychosocial risk assessment, the reality is that, people are going to complain about potentially their PPE, or they might complain about workload, or it's all of these things. They are all barriers to doing a job safely, ultimately, aren't they?
And if they complain about their PPE, do something about it.
Yeah, yeah.
Because a good fitting pair of work shoes, honestly, you could have given somebody a gold ring. I've spent a lot of time over the years making sure that when we're talking safety footwear, it fits. Yes, it might cost 20 or 30 pounds more to provide a better pair or a different pair that actually fits. But you've got someone who's not distracted by tired feet.
Mm. You've talked about the standards, but I'm interested also in surely suitable, sufficient, well-fitting PPE. That's a legal requirement, isn't it? So, how can we say that actually inclusive PPE is not a legal requirement?
So if you go back to the PPE regulations, the 1992 regulation, it's actually really clear. It was incorporating the language from the 1989 directive that I quoted right at the start of the session. So it's already the law. The thing is, up until now, it's been very easy for organizations to say, but this salt's available. And thanks to the work that's been done by a number of people, mainly in the construction and heavy industries area, we now see an awful lot of manufacturers producing wider ranges of sizes that are there for different body shapes.
Mm,
And as I say, I have, even in my environment, which is laboratory research and pharmaceuticals, getting a laboratory coat to fit for everybody is actually just as difficult as getting a pair of overalls. In fact, I'm now going back 25 years ago, where I had to buy a bolt of fabric, find a local seamstress in the pattern, and get laboratory coats made. And most employers wouldn't think to go that far. But we had somebody who they were actually having to tie a bit of string around their arm to stop the sleeves falling down over their hands. Yeah, they were having, even the smallest lab coat we get was coming to their feet. But at the same time, I mentioned someone very tall. I had several people in that laboratory who were well over 2 meters tall. And, the laboratory coats more looked like a laboratory waistcoat. And for all you might laugh, you get the biggest one and you go, okay, fine, I think I've got something long enough, but I can fit 3 of you in there. So just from a point of view of productivity, of making those individuals comfortable in the lab, I got into the habit of, for those people at either end of the anthropometric ranges, just getting things made for them or altered for them. But the gratitude you get back for that is immense.
mm,
So imagine what you would get if you are in a heavy industry environment and you find that size 3 rigger boot for that lady who is of
yeah.
diminutive stature, or even finding a size 10 in a woman's last. because most women's footwear only goes up to a size 8. And it is perfectly possible now. The suppliers exist. But
It
even
is possible, and I think that it is tricky for organizations, isn't it? I mean, holding a massive inventory for a start, and that's the first thing. I was in a quarry a couple of weeks ago, 150 men and 2 women, and when I rocked up, I was flipping lucky they had boots in my size. I tell you that they didn't have trousers, because and they're a smallish business, so as small businesses, that does require you to be very planned and making sure that you've got sizes beforehand, you've got inventory, you've got access to its stock, isn't it?
but there's a big difference between visitors who, as long as it's approximately right, you'll probably be fine. To
Yeah.
someone who's going to be working for you long
That's
term.
true. That's true. That's true.
So coming from Edinburgh, there's an independent PPE stockist up there who I I don't know whether you mind me advertising or not.
Go for it.
But Hewitt's
Yeah.
up in Edinburgh, and wherever I had someone who was particularly tricky looking for field work, personal protective equipment, I used to just send them down to Hewitt's and say, find something that fits.
Mm.
And we had an account with them. And so there would just be a phone call then
Yeah.
through to
That's
myself and say,
ideal.
I need a purchase order for,
Yeah. Yeah.
you know,
I moderated a debate about 9 months ago about this, and one of the challenges which came out was that, and you'll know this from all sorts of things, that health and safety are not always brought into the procurement process. So it's, they might come up with what they want, and then procurement will just completely miss the point and will go with something else or some other cheaper option. So having those relationships and educating procurement is important as well, isn't it?
absolutely. And in the past, I've written a procurement standard for PPE, but I've made it abundantly clear when I was helping procurement with that this will only provide PPE for maybe 9 out of 10 of our people. And they go, oh, well, so what about the 1 in 10? I'm going to send them to this local independent stockist.
Yeah. Yeah.
And
Yeah.
and we'll just maintain a relationship with them for
Mm,
um albeit the more challenging people
mm,
to provide for. But that doesn't mean our duty is any less. If anything, it means our
no.
duty is more, because if we don't um, acknowledge that one size does not fit all, in fact, one size effectively fits no one,
Mm,
um, then we're actually knowingly putting those employees at risk. And there are a lot of small independent stockists out there who would love to have just 10% of your business.
that's true. That's very true. What I can't remember. I was trying to follow this bit, and I might have missed it. But I heard you say that, for example, migrant workers, it was low socioeconomic status, there is a higher risk of them having car accidents. I remember hearing that, and I thought that it made me slightly grimace, because when I got divorced, my insurance premium went up, and I had no idea why. And I was like, "Why? This isn't right." But obviously, as a divorced person, your risk increases apparently. But in
It
general,
actually does.
yes, apparently so. So now I understand why. But in general, when we talk about some of these minority characteristics, is there other evidence that shows that you've said that they are more likely to, oh, this was on car accidents again, have uh, much more serious injuries. But
Yeah.
are there any stats which show that that in general minorities are having more serious injuries or more accidents, or proportionately, as it were?
So I've not seen that. in terms of if we're talking racial minorities, for instance.
Yeah. Yeah.
I've not seen good data on that. It's
Right.
all been around other characteristics that are actually common, independent of our ethnic background.
Yeah. So that's the socioeconomic status specifically. Okay.
So
Interesting.
the big ones appear to be things like anthropometrics, socioeconomic
Mm,
status, communication, migrant worker status.
yeah.
Uh,
Yeah.
these all have a direct bearing, especially in the more serious end of accidents. And after all, that's probably what we're interested in. I don't want
Yeah.
anyone having a paper cut. We all know how sore they can be, but I certainly don't want someone having a major fracture.
No. No, of course.
And
And
actually, these
go on.
characteristics are telling us that they are much more likely to be involved in those type of accidents. Now, is it that they are perhaps due to being a migrant worker or it being precarious employment, more willing to please, more willing to put themselves in harm's way? Well,
Maybe. Yeah.
then that means we've got to spend a lot more time with people who
Yeah.
might have a different threshold of risk to us.
Yes. Yeah. 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 So I have got quite a detailed one here for you, but I think it's a good one. So this came in from a woman in health and safety, and she says the recent highly publicised decision by Police Scotland to ditch their clean shaven policy after 4 staff members successfully took out legal action has resulted in a lot of discussion in her organisation. So she works for a large healthcare organisation that requires clinical staff to be fit tested to a close-fitting FFP3 respirator for protection against biological hazards. In order to provide sufficient protection, male staff members need to be clean shaven on the day where they're fitted and whenever they're used clinically. Um, if they don't work in an area normally accommodating infectious patients, they're permitted to have facial hair during day-to-day duties. Under the agreement, they shave within the region of the mask seal in the event of an outbreak in their area. If staff were to wear FFP3 respirators whilst not clean shaven, they could be exposed to airborne infection, present a risk themselves, colleagues, and other patients. There are growing numbers of staff members refusing to shave in order to be fitted to FFP3 masks on the basis that it's discriminatory against those with facial hair. Loose fitting alternatives are available. Um, However, for those with high consequence infectious diseases, these are unsuitable for infectious control reasons. So, this lady wanted to know your opinion on this from an EDI perspective. If staff with facial hair were not required to shave to wear FFP3s, there's also a risk that clean shaven staff members will be subjected to more frequent contact with infectious patients, which also seems to be discriminatory. Staff who are unable to be clean shaven for religious or occupational health reasons are generally allocated elsewhere in these instances. However, significant difficulties will be presented in trying to accommodate non-clean shaven staff in a similar way. So there you go. That's an excellent question for you.
Beards and respiratory protection.
Yes, that old chestnut.
And that has been kicking around for as long as I've been in health and safety. Uh, you've identified quite rightly, some people don't shave for religious reasons. As I've discovered through my career, some men, to be quite frank, can shave and then still fail a face fit test because they grow facial hair at a prodigious rate. So I notice infection control came into this. So one of the things that I would definitely be considering here is airflow hoods. Something I've had a lot of success with in the past. If there is a problem with the hood bit itself moving between patient to patient, you can either get hard plastic ones that can be sprayed down with disinfectant, or you can get disposable covers that are a few pounds each that go over what's inside. And in actual fact, in what might be a hot working area, the downflow of clean air over the face is actually very pleasant. And they can be very well tolerated. And I certainly know that there are a lot of companies that make them, 3Ms and Sunstrom would be two that I'm very familiar with, but there are many, many of them. Now, whether that's going to interact with patient care, whether it's going to pose other infection control issues, I'm not sure. But that would tend to be the line that I would go down in that kind of environment. And certainly, as a background working in infectious disease research, that is a direction we went down quite early as soon as they became cost effective.
It's a very good answer. Thank you. Yeah.
Well, they're now in the region of hundreds of pounds, maybe mid hundreds of pounds.
Mm-hmm.
But your FFP3 masks can be £2 or £3 each. How many disposable masks do you have to use before an airflow hood actually becomes cost effective?
Financially, yeah.
Especially as FFP3 masks, according to the standard, shouldn't be worn for more than a couple of hours at a time. And that's because of the respiratory strain that it puts on your lungs. So I would say reframe your question and say actually what's most suitable for all here.
Very good. Thank you very much. I mean, I would kind of like to sort of wrap this up by talking about some of the conversations in health and safety at the moment are very much sort of back to basics. And they're very much about, we just need to do more risk assessments. We just going back to worrying about serious SIFs and saying we need to go back to basics. And for me, what this conversation really highlights is that when we started in health and safety, we were not aware or didn't think about some of these nuances, which actually make an enormous difference. So, thinking about minorities, thinking about stress and how it impacts, thinking about communication and how we communicate with migrant workers, these are all nuances which are if you're just doing a risk assessment, it's not going to be suitable and sufficient for everybody unless you're considering some of these things, is it? So that's my sort of final takeaway from what you've been talking about, Rosie. Is there anything you'd like to say to finish off?
I'd ask a simple question, and it's who is the expert on the work being done? Often the worker. And unless they've got the space and time to input and really understand the risks and really understand what risk mitigation is possible, you are going to miss things. And if we go straight back to the Health and Safety at Work Act, training, information, instruction, and supervision. And the bit that we forget is validating our training. We're very good at instructing people. We're very good at supervising people, but we miss the information bit and allowing people to truly understand the risks that they are working with and then communicate back to you their understanding of that often shines a light on things that you would not have thought about.
Thank you so much, Rosie. It's been an absolute pleasure spending an hour with you today. I'm going to wrap this up, put it in the can, and we'll send it out. Thank you so much.
Thank you, Heather.